Welcome. In this second session on spontaneous eye movements, we'll be talking about a few more important forms of nystagmus as well as nystagmoid eye movements. Pendular nystagmus can be congenital or acquired. Congenital pendular nystagmus is usually horizontal. Acquired pendular nystagmus can be a combination of horizontal, vertical or torsional movements, making the resulting movement of the eyes oblique, circular or elliptical. Between the two eyes, acquired pendular nystagmus may be asymmetric or monocular, may be conjugate, disconjugate or disjunctive, and pendular nystagmus has been found with multiple sclerosis, brainstem and cerebellar infarction, and with poor vision, with the eye having the poorer vision having a larger amplitude of the nystagmus. Oculopalatal myoclonus is a vertical pendular conjugate nystagmus associated with rhythmic contractions of the soft palate. So along with the movement of the eyes, there is movement of the soft palate also. Along with the soft palate, adjacent facial and oropharyngeal muscles may also be involved. Oculopalatal myoclonus characteristically occurs after infarction in the Guillain molar triangle and usually occurs weeks to months after that infarction when hypertrophy of the inferior olivary nucleus develops. Seesaw nystagmus is an important form of nystagmus to remember, and it is a pendular nystagmus with a low frequency disjunctive pattern. In the classic seesaw nystagmus, one eye elevates and intorts, and simultaneously the other eye depresses and extorts. And this phase is followed by a reversal of movements between the two eyes. So it appears as if the two eyes are at the two ends of a swinging seesaw. The typical seesaw nystagmus occurs with a paracellular lesion, and craniopharyngioma is important to remember. It may also occur with trauma and hydrocephalus. Congenital albinism may also have a seesaw nystagmus pattern, but with the elevating eye extorting instead of intorting and the depressing eye intorting instead of extorting. Lesions in the midbrain may also have a seesaw pattern nystagmus, but instead of it being pendular, it has a jerk component. And seesaw nystagmus may be asymmetric between the two eyes with larger amplitude in the eye with the poorer vision. Nystagmus can also occur with internuclear ophthalmoplegia or INO, and INO we have covered when discussing nuclear and infranuclear disorders of eye movement. This picture shows a right internuclear ophthalmoplegia arising from a lesion in the right medial longitudinal fasciculus. As a result of the lesion in the right medial longitudinal fasciculus, when the patient attempts a left gaze, there is slowed adduction saccadic velocity of the right eye and a nystagmus of the abducting left eye. The nystagmus is a jerk nystagmus with the fast phase towards the left side, and the slow phase has a decelerating velocity. Now we come to spontaneous eye movements, and the first pattern of spontaneous eye movements is saccadic intrusions, which we have discussed when discussing disorders of ocular fixation system in the supranuclear control of eye movements, and we are going to skip this topic in this session. Voluntary flutter, also known as voluntary nystagmus, is not a nystagmus by definition. It is voluntarily initiated by the subject, is ill-sustained in nature, and is usually found along with convergence, facial grimacing or eyelid flutter. Voluntary flutter is typically a high-frequency conjugate horizontal back-to-back saccades without intersaccadic interval, and there are no other neurological associations with voluntary flutter. Induced convergence retraction, more commonly known as convergence retraction nystagmus, is another form of nystagmus which we have to remember. It occurs in dorsal midbrain syndrome or Parinot syndrome, and in this form, on attempted upward saccade, there is co-contraction of all the horizontal rectus muscles, resulting in retraction of the eyeballs because all the horizontal rectus muscles contract together, and convergence, as the medial recti are more powerful than the lateral recti. Because of these two movements on attempted upward saccade, it is called a convergence retraction nystagmus. and the upward saccade can be stimulated with a downward rotating ocular ram. Superior oblique myokymia occurs due to contractions of the superior oblique muscle, and these contractions are short-lasting. Frequent paroxysms are monocular nature and occur with a very high frequency. And during these paroxysmal episodes, there is repeated depression and intorsion of the involved eye. During the paroxysmal episodes, the patient perceives oscillopsia, vertical or oblique diplopia, blurred vision, and sensation of eye movement. The paroxysms may be provoked by downgaze and blinking. Slit lamp examination during the paroxysms can detect movement of the conjunctival vessels, demonstrating the repeated high-frequency depression and intorsion of the involved eye. And superior oblique myokymia has been attributed to the compression of the fourth cranial nerve root either by the posterior cerebral artery or the superior cerebellar artery. Oculomasticatory myorhythmia is another form of spontaneous eye movement which is associated with contraction of masticatory muscles, and this occurs in Whipple's disease. The eye movement found in oculomasticatory myorhythmia is typically of a pendular vergence type, so in one phase both the eyes converge and in the next phase both the eyes diverge. In Whipple's disease, oculomasticatory myorhythmia can also be associated with a vertical saccadic palsy. Ocular bobbing and dipping occur with severe neurological deficits. In ocular bobbing, which occurs with massive pontine lesion, a fast phase moves the eye downward from the primary position to a downward position, and the eye remains in that downward position for a brief interval, followed by a slow movement which returns the eye from the downward position back to the primary position. In reverse ocular bobbing, which occurs in comatose states, there is a fast phase which displaces the eye from the primary position to an upward position, and after the eye remains in that upward position for a brief interval, there is a slow movement which returns the eye back from the upward position to the primary position. In ocular dipping, there is a slow downward phase which moves the eye from the primary position to the downward position, followed by a fast phase which returns the eye back to the primary position from the downward position. Coming to management of patients with spontaneous eye movements, and there is a list of abnormal spontaneous eye movements which demands neuroimaging. These include Hyman-Bielczewski's phenomena, Spasman-Newton's, asymmetric gaze evoked nystagmus, central vestibular nystagmus, acquired pendular nystagmus, seesaw nystagmus, and superior oblique myokymia. We have discussed these conditions in this and the previous session. Management of spontaneous eye movements can be medical, optical, or surgical, and we have to remember that baclofen is a definitive treatment for periodic alternating nystagmus. In vestibular nystagmus, the treatment goal is to reduce the vertigo, and this can be done with anticholinergics and antihistamines. And there is a long list of medications reported to be efficacious in various patterns of spontaneous eye movements. And these include, in addition to baclofen, 4-aminopyridine, gabapentin, carbamazepine, and other drugs. Now we have to remember that immunosuppressives including steroids can be used to control the oscillopsia of ophthalmoplegia, and for patients with congenital, latent, and acquired nystagmus, we can also use botulinum toxin A, either retrobulbar or intramuscular. Optical management of spontaneous eye movements include base-out prisms in congenital nystagmus or INS in order to increase the effort of convergence by the patient, and we know that in these patients the intensity of nystagmus decreases with increase in the effort of convergence by the patient. In patients with accommodative esotropia associated with latent nystagmus, correcting the accommodation may correct the esotropia and the latent nystagmus. Spectacle prisms can be used to shift the primary position towards the null point, because at the null point the intensity of the nystagmus is minimal and visual acuity is better. Surgical management of spontaneous eye movement include the well-known Anderson-Kestenbaum procedure, which is typically performed in congenital nystagmus, and it also shifts the null point towards the primary position, and it involves resection and recession of the horizontal rectus muscles. However, following Anderson-Kistenbaum procedure, nystagmus may recur months or years later. Other procedures which have been described for spontaneous eye movements all involve weakening the extraocular muscles, and they include retroequatorial recession, myectomy, removal and reattachment of the muscle insertions without changing the insertion site, and superior oblique weakening in superior oblique myokymia. And if we can identify a neurological lesion for the spontaneous eye movement, a neurosurgical procedure can also be performed. Thank you for listening.